advances for those of you who are more knowledgeable in this area. So to begin, I think a few definitions are in order. When we talk about ART in the United States, specifically we mean any fertility treatment in which the woman's eggs are removed at some point. So the ART does not encompass inseminations, IUIs, some of the other treatments that you may be familiar with. It's specifically something where the eggs have been removed. Now historically, there are a number of ART procedures, GIFT, ZIFT. These were procedures where embryos or eggs and sperm were put into the woman's fallopian tube surgically using laparoscopy. That is really of historic interest. In the US currently, ART really means in vitro fertilization. Now, why would a couple undergo IVF? Well, there are a number of indications. Historically, the classic indication was tubal disease. So women whose fallopian tubes were irreparably damaged or had been removed, sperm and egg cannot get together by any other means. And so IVF was actually invented to deal with this problem in the 1970s. But the indications have been expanded dramatically. Endometriosis, male factor infertility, and the landmark breakthrough was the development of ICSI, or intracytoplasmic sperm injection. Unexplained infertility, a very frustrating but a very real diagnosis that affects about 10 to 20% of couples suffering infertility. And finally, IVF is necessary if one is going to perform pre-implantation genetic diagnosis, PGD, PGS. Now, IVF versus tubal surgery, there really is no contention at all. IVF is far more successful than traditional tubal surgery in most cases, and is additionally more cost-effective. Even 20 years ago, a study was done looking at the economics of tubal surgery versus IVF and showed that the cost per live birth was actually less expensive with IVF. So tubal surgery, particularly microsurgery, is really a thing of the past. Endometriosis, as some of you may know, is a condition in which abnormal tissue is implanted in the woman's pelvis. This is a surgical diagnosis. It is diagnosed by laparoscopy, and usually it is treated at the time of initial diagnosis. But in cases where surgery does not affect a pregnancy, or where the disease is inoperable, a frozen pelvis, IVF is the most successful modality. And in the experience of Cornell, happily, IVF success rates are similar irrespective of how severe the disease is. Unexplained infertility, again, a very frustrating and heartbreaking condition. By definition, it's a process of exclusion. All diagnostic tests have been performed. The male and female seem to be normal, and yet they're not getting pregnant. Happily, if you look at a young couple in their young 30s with 2 years of unexplained infertility, some of them will indeed get pregnant on their own, albeit at a relatively low rate. Without treatment, it's about 1 to 4% per month. But over time, this results in about a 40% success rate in about 2 years of trying. But most couples aren't going to wait 2 years to see if they're in that 40%. Typically, we will start with low-tech options in this situation, inseminations, clomiphene, injectables. But finally, if these things do not work, IVF is the most successful. Now, irrespective of the reason for doing the ART, whether it's a male factor or what have you, a certain evaluation of the female partner is imperative before undertaking treatment. And it focuses on evaluating the woman's uterus and also her ovarian reserve. Now, the uterine cavity can be assessed by many different means. The first and original test was the hysterosalpingogram, or HSG. This is an X-ray study where contrast dye is injected into the uterus and tubes, and it gives you an image of the inside of the uterus and the tubes. More recently, many programs are using sonograms more frequently, what's called a sonohysterogram, where sterile salt water or saline is injected into the uterus, and this gives also a very nice image of the inside. Hysteroscopy is a surgical procedure where a fiber optic telescope is used to examine the cavity. But most importantly, whatever technique is used, if a fibroid, a polyp, scar tissue, anything that could affect implantation is discovered, it should be surgically corrected, usually by hysteroscopy. Now, this is an HSG with a normal uterine cavity, nothing in the cavity that should not be there. By contrast, this would be an abnormal HSG with a large filling defect. In this case, it turned out to be a polyp, and this will be corrected before ART is undertaken. Now, ovarian reserve, I think, is a very confusing topic for patients and I think for some physicians, particularly general OBGYNs. What ovarian reserve really means is the quantitative endowment of the woman's ovaries in terms of how many follicles and eggs she has. It is age dependent. It does decline with time, but it is not predicted by age alone. There are women in their 40s who have very good ovarian reserve and respond very well. And conversely, there are women in their 20s who have very low ovarian reserve, sometimes premature ovarian failure. But an important caveat, and I think this is important for everybody to understand, there is no reliable test of oocyte quality. Reserve does not mean good eggs or bad eggs. It simply means the quantity. Now, with age, ovarian reserve diminishes because of depletion of eggs. A woman is born with approximately 1 or 2 million eggs By the age of her first menstrual period, typically at 12 or 13, she is down to 300,000 eggs, and about 1,000 are lost a month thereafter until the age of menopause. Now, we have a number of tests that we use to assess ovarian reserve. Now, this is important not for turning a patient away from treatment, but for selecting the appropriate stimulation protocol for IVF. Classically, we relied very heavily on the FSH level. On day 2 or 3 of the cycle, the FSH and the estradiol. More recently, and this is why I've highlighted them, we are relying more on the antral follicle count, which is an ultrasound procedure where we measure the visible follicles that we can see in the ovaries on the early part of her cycle. And the AMH, or anti-Mullerian hormone, is a blood test, which is superior to the FSH, and I think will supplant the FSH because it really does not vary across the cycle. I can measure it on day 23 or day 2 and get the same result, and it does not fluctuate between cycles the way the FSH does. Now, just to give you a sense as to the optimal parameters, most programs would like to see the FSH less than roughly 10. Antral follicle count, we would like to see between 7 and 10 resting follicles in the ovaries on ultrasound. And the AMH level, typically, we like to see greater than 1. Now, I'm going to talk a little bit about ovarian stimulation for IVF. Now, what are the goals of ovarian stimulation? Why do we not do this in the natural cycle? Well, again, classically, it was because we wanted to replace multiple embryos. So in the earlier days of IVF, even in the late 1980s, early 90s, we were routinely replacing 3-4 embryos into the uterus, even of our youngest patients. And this was because IVF was a far less efficient and successful process. Now we're very concerned about the risk of multiple birth, but we still want multiple eggs and embryos, and this is more for the purpose of embryo selection. So you can select embryos by grading them, looking at their shape, their morphology. You can grade them perhaps by letting them grow longer in vitro to day 5 and let them self-select to the blastocyst stage. Obviously, if you're doing genetic testing, PGD, you want multiple eggs and embryos to work with. And finally, if you're going to be freezing embryos or eggs, it's desirable to have innumerable eggs. Now, this is what we'd like to see during a stimulation protocol. These are 2 ovaries with multiple follicles developing in a synchronous fashion. Now, for stimulation, the mainstay of the drugs that we use are what are called gonadotropins. Again, most of you probably know HMG is a combination of FSH and LH. And FSH and LH can be obtained either from the urine of menopausal women, or it can be made by recombinant DNA technology. The earliest gonadotropin preparation that was used widely was, of course, Pergonal, and it was the work of Bruno Lunenfeld that isolated this. Menopausal women produce huge amounts of FSH and LH, so it can be isolated from the urine, and classically it was collected from the urine of Italian nuns. More recently, with recombinant technology, we can take the genes that make FSH and LH and HCG, put them into a Chinese ovary cell line, and then produce a very pure form of this in a reactor. Now, when we stimulate the woman to make multiple eggs, her estrogen, of course, gets potentially quite high. That can fool the body into thinking it's time to ovulate and trigger an untimely LH surge. So we have to use a GnRH agonist like Leuprolide or a GnRH antagonist like Ganirelix or Cetrorelix to prevent this from happening. Now, this little schematic here gives you a timeline of a typical IVF cycle. In this case, if we use something like Leuprolide in a long protocol, the woman starts this agonist about a week before her period. She gets her period, comes into the center on day 2 or 3. On day 2 or 3, we give the FSH and LH injections along with the Leuprolide. This goes on from about day 3 to about day 10, 11, 12, at which point we trigger the maturation of the eggs with an injection of HCG. We then have to retrieve or harvest the oocytes 34 to 36 hours later. They are fertilized in vitro and then transferred back into the uterus either on day 3 or day 5. Subsequent to the egg retrieval, we do put the woman on supplemental progesterone for the purpose of enhancing implantation. If we use a GnRH antagonist like Ganirelix or Cetrorelix, it does not have to start till later in the stimulation, so it is fewer injections. The stimulation starts on day 2 or 3 with FSH and LH, and then we add the antagonist later to prevent the surge. Now, egg retrieval itself in the early days of IVF was, of course, surgical. It was a general anesthesia, it was a laparoscopy. Somewhere in the mid to late 80s, it transitioned to an ultrasound approach where the woman receives intravenous sedation, and the actual vaginal retrieval with a needle is about a 5 or 10 minute procedure. Here you can see a follicle in the ovary. This is a little puncture line on the ultrasound. You can see the needle has entered the follicle where the fluid will be aspirated. And then the fluid is delivered to the laboratory next door where the embryologist finds the oocytes. And with conventional insemination, not ICSI, they simply concentrate some washed sperm of the male partner and add it to the oocyte in the dish. And these are the stages of development through the earliest fertilization. This is a mature oocyte. The egg, the zona pellucida is the shell around the egg. This is the earliest of a sign of a fertilized egg. So this would be day 1 after retrieval, where you can see the male pronucleus and the female pronucleus. This would be day 2. The embryo is now cleaved to 4 cells. And day 3, which is a common day for transferring, where the embryo is now optimally about 8 cells. Now, as I've mentioned, embryo transfer can be performed on day 3 or day 5 at the blastocyst stage. Most programs use a soft catheter because we want it to be as atraumatic as possible. And there is the option of using ultrasound guidance. Some programs use it routinely, some use it selectively. Now, this is a day 3 embryo, so this is 6 cells. But to give you a perspective, this is the size of a human embryo relative to the tip of a needle. And these are some very healthy-looking day 5 blastocysts, which are at a much more advanced stage. Now, the argument for blastocyst transfer is that prolonged culture of these embryos allows the healthiest, hardiest embryos to self-select and make it to day 5, thereby improving their implantation chances. It's not necessarily that an embryo is better on day 5 than day 3, but it helps you determine. And so therefore, we put fewer back, typically 1 or 2, and this reduces the risk of multiple pregnancy, particularly high-order multiples. And this is the soft catheter that we use for the transfer itself. Now, the bottom line, of course, is success rates. And one thing that I will say now, and you'll hear over and over, is that maternal age is probably the single most important determinant of ART outcome. When a doctor in another field comes to me and says, what is the success rate of our IVF program? I'll say, at what age? I mean, that is a very important factor. So advancing age alone should be considered a fertility factor, and clearly it is very important to expedite the evaluation and treatment when the female partner is 35 or older. So pregnancy outcomes by age, if you plot them from age less than 30 all the way up to 44, you can see a very progressive decline with increasing age. This is about a 10-year interval at Cornell. This is about 3,000 or 4,000 cycles, going up to the mid-90s. And for the youngest patients, you're talking about 50+% live birth rates. It's about half that at age 40. By 44, the live birth rate is about 5 or 6% per transfer. So we do get pregnancies, albeit at a very low rate. Now, you might think this is because we have fewer eggs. Are we putting fewer embryos back in our older patients? In fact, the opposite is true. We tend to put back 1 or 2 embryos in our youngest patients and be more aggressive, 3, 4, et cetera, in our older patients. So the thing that decreases pregnancy rates with age is not the number of eggs in embryos. It is the quality of each individual embryo, which is primarily genetic. Now I'm going to try to touch on a few more contemporary aspects of ART. I'll talk briefly about male factor. I'll talk about pre-implantation genetic testing very superficially because Dr. Scott, I think, will be focusing on this afternoon. I'll talk a little bit about egg freezing, and then finally, co-culture. Now, when you talk about IVF for male factor, you're really talking about ICSI. Now, ICSI was first performed successfully in Brussels in 1992 by Jean-Pierre Palermo, who directs the ICSI program at Cornell currently. And initially, it was used for men with very poor sperm quality, very low counts, motility. But now it's been extended to surgically retrieved sperm, a topic that Dr. Schlegel will be addressing, and I think is also important for men with cancer who have frozen sperm before undergoing chemotherapy. Now, just to talk about the ICSI procedure technically, obviously we're doing very fine microsurgical motions under a microscope to very microscopic objects. So this requires a special type of an inverted microscope, and then a device called a micromanipulator, which translates hand motions of the embryologist into very fine little microsurgical motions on the microscope stage. Here you see the needle that's used to inject the sperm. These are 2 mature human sperm. The sperm are immobilized, paradoxically. You want motile sperm because that tells you the sperm is alive. If a man has sperm that are not moving, you don't know whether they're just not swimming or whether they're dead, and a dead sperm will not fertilize an egg. But if you have an actively motile swimming sperm, you do not want to have that sperm in the egg thrashing its tail around, which could damage the egg in theory. So we actually immobilize the sperm by compressing the flagellum, or the tail, close to the head before injection. The sperm is then drawn tail first into the injection pipette. You can see the head of the sperm there. The needle is thrust through the zona pellucida and into the center of the oocyte, where the sperm is deposited. Now, if you look at ICSI outcome, again, it's very similar to IVF outcome overall, but does change with advancing maternal age. Pre-implantation genetic diagnosis. Well, this is a real alphabet soup. You'll hear about PGT, BGS, PGD. I'll start talking a little bit about PGS. Now, this is a technique where you're assessing the number of chromosomes. This is not looking for single gene defects. This is looking for, are there missing chromosomes, are there extra chromosomes? And there are a number of techniques that you'll hear about that many centers use. The classic technique was FISH. This is limited in that it only allows you to look at a certain subset of the chromosomes, maybe 9 or 11 out of 23 pairs, using color-coded probes. More recently, most labs are adopting techniques such as CGH, or comparative genomic hybridization, or SNP microarray analysis, which allows you to test for all 23 pairs of chromosomes and additional factors. Now, what are the potential applications of PGS, of counting the chromosomes? Well, potentially it could treat recurrent pregnancy loss, potentially it could treat couples with unexplained IVF failure, and potentially age-related infertility. But I think more research will have to be done to see if this really does translate into better success rates. Now, this is a normal human chromosome analysis, or karyotype. In this case, 46 chromosomes, and this is a male, X and Y. When you're performing a PGD on day 3, you take the embryo, which is now 8 cells, you drill a hole in the zona either with a laser or by melting it chemically, and then you pull off a single cell or blastomere, which will be analyzed. Now, with FISH, again, you're looking at chromosome numbers using color-coded probes. With this technique, the cell's removed, put on a slide. You hybridize with these color-coded probes to the nucleus, and then you analyze it under an ultraviolet microscope. Now, this is a FISH picture of an abnormal embryo, in this case, Down syndrome. So here you can see 2 chromosome 16s, you can see an X and a Y, but you see 3 red dots, which represent chromosome 21. So this is a trisomy. This is not an embryo that you would want to replace. The newer techniques such as CGH and SNP microarray, which I'm not going to dwell on now because you'll hear this extensively this afternoon, enable us to look at all 23 pairs. Now, I think a classic and important indication for pre-implantation genetics is PGD for single gene disorders, the couple that carries a disease that could be transmitted to the offspring. And there are 2 basic types of disorders, what we call dominant, which means only one parent has to carry the gene to have an affected child. And this includes things like Huntington's disease, myotonic dystrophy. More commonly, we're dealing with recessive disorders where each parent has to carry an abnormal gene, and it's passed on to 1 in 4 children. And this includes things like cystic fibrosis, sickle cell disease, Tay-Sachs. We performed the first successful PGD for sickle cell disease at Cornell. This was a couple that had had 3 consecutive pregnancies with sickle cell disease, and these were their first unaffected twins born after this procedure in 1998. Now, you'll hear a lot about egg freezing. I'm going to touch on this briefly, but I think this is an area where the state of the art has improved markedly in the last few years. It is a fantastic option to have for single women who are confronting a diagnosis, for example, of cancer, where they might be receiving chemotherapy, a bone marrow transplant, but they need to bank their eggs because they can't be fertilized before undergoing this therapy. Now, for pre-adolescent girls, or for women that don't have time to undergo IVF, they have leukemia, they have to be treated within days, not 2 or 3 weeks, we still have to do ovarian tissue freezing, where we perform a laparoscopy and either biopsy the ovaries or remove an ovary.